It's a great privilege to have Dr. Tricia Woodhead with us today, who is going to be speaking to us about quality tools. And it's indeed a pleasure to have participants from all over the world joining us for this very interesting and important webinar on quality tools. So let me first introduce the moderator for the day and hand over to the moderator. We are very pleased to have Dr. Colonel M. Dayananda, who's going to be moderating the session today. Sir is an MBBS graduate from JJM Medical College, Mysore University. In 1976, he completed his MBBS. He holds a master's degree in hospital administration from the All India Institute of Medical Sciences, New Delhi. Dr. Colonel M. Dayananda comes with a very wide experience in the field of hospital administration and has served in various hospitals across the country. He is an advisory committee member of the Bureau of Indian Standards, which is presently developing quality standards for the hospitals in India. He has edited a handbook on management of military hospitals. His last assignment was in the capacity of Medical Superintendent of Kasturba Medical College Hospital and Chief Operating Officer of all teaching hospitals of Manipal University and Sikkim Manipal University. He is currently serving as Director of JSS Hospital, Mysore. So over to you, Colonel Dr. M. Dayananda, to take the session forward.
Good afternoon to everyone, and thank you, Dr. Lalu, for inviting me to this very prestigious seminar, the webinar through webinar which we are conducting. Firstly, I would like to talk about the healthcare itself, which is unique, and it has got many variations and diversions compared to other industries or any other thing where the quality tools can be very easily adopted. We have a very unique situation in terms of the difference in terms of the skill sets that we have and the people in the team which interact and ultimately to produce, that is the patient care and the patient services. It becomes very difficult and complex to adopt any kind of measurement tool in the system. However, the main aim of this quality and this adoption of quality tools in the medical care or the patient care is bringing about great changes in our practice of medicine. What we saw before, by individual practice of medicine, where individual doctor is to treat completely the patient right from the beginning to the end, is not so. Now we have what is the situation is the team care, a complex type of people, right from the clinicians, super specialists, the specialists, the nurses, the non-technical people, all involve themselves in providing care. So the multiplicity as well as the chances for failure also increase during this kind of multiple processes. Understanding communication is also very important. However, coming in of the quality tools in various types of tools that we have, Dr. Tricia will be talking about it a little later, have brought in huge difference. Firstly, the difference in the patient safety itself. We used to have, and probably 1 in 9 patient in the hospital have to have some kind of a failure or a medical error or something like that, which resulted in kind of a ill effect on the patient. Whereas coming in of these quality tools, we have improved drastically, we improved very well in terms of reducing this kind of mistakes or deficiencies and increasing the efficiency, making things much simpler as well as more effective, be it right from the patient registration itself. The experience of the patient need to wait to see the consultant, and the process of consultation and the process of various the diagnosis that we make in the laboratories, the standards that we have improved so perfect that in terms of what we used to practice about 40-50 years, it's not so. Clinician has become totally dependent on very accurate diagnosis that happen, for which hugely we have to thank the quality tools that have brought into the laboratory systems, diagnostic systems, where that has contributed to very less number of mistakes or errors on which the clinician is very dependent on, and he completely believes the report given because the standards are so high, because we brought in external quality assurances, internal quality assurances. So all this has improved the medical care in a tremendous way. So every day we'll be seeing that these challenges are there in hospitals, that is solved and brought by this kind of interventions, that is the quality tools. That is how the quality tools are so important. And we have many interventions that we have carried out in the hospitals, be it in the service areas like CSSDs, the the laundry system, CSSDs, and various other in the OTs, which we have checklist system and other things, which have brought in huge amount of improvement in the patient care. Standard of care is improved, patient safety has improved, and as well as the accuracy of delivery of care has improved, as well as the confidence of the patients as well as their relatives in the healthcare services also has improved. This is all because of various levels of quality tools that has been introduced at various levels of care that happens in a hospital. So to talk about all this, probably I have a better person than, we can't have a better person than Dr. Tricia Woodhead. And she is a board member and person-centered care expert. It's the first time I'm hearing this term. It's a wonderful term rather than just calling patient-centered this thing. It's a person-centered care expert of ISQua. And she's an associate clinical director for patient safety, West of England Academic Health Sciences Network. We would like to hear from you, madam. And I think over to you. Welcome, madam.
Thank you. Thank you very much for that introduction. And it's an absolute pleasure to be here today to speak to you. So it's an absolute pleasure today to talk to you about quality tools. And in doing so, I have tried to put together a short presentation that I hope will give you the opportunity to think differently about the tools that you use and to think differently about the context in which you are using them. My background is as a consultant diagnostic radiologist for some 25 years in the National Health Service in the UK. I've also had the opportunity to be an executive medical director, and in the last decade been very deeply involved in the delivery of patient safety, both here locally in the southwest of England and across the United Kingdom in various roles and responsibilities with and for our Royal Colleges and for our wider NHS management. So what I've tried to bring to today's description of quality tools is a bit of radiology, the idea that there's a structure and there's an approach and there's a context, some very practical advice and guidance that's come from real-time frontline connections, both as an improver myself, but as an improvement coach. And then lastly, as you've already understood, my passion for involving and including the person who is at the center of all this, that is the patient and their family and their friends and colleagues. So as you already know, I'm a board member of ISQua, which is a real privilege. And I've also, in the last 5 years, developed an expertise in online learning. And that is today a real opportunity for me to broaden that experience and build on it. At the end of this presentation, I'm hoping that you will have a framework with which to consider the range of tools that we use in improving quality in healthcare. Secondly, that you'll have a clearer understanding of how to use them and the context in which you use them and how that can influence both their effectiveness and their usefulness. And then lastly, my real aim is to give you greater confidence, not just to look at quality in your healthcare system and in your team and in your specialty, but actually to do something about it. Because unless we do something, nothing changes. So as has already been mentioned, healthcare is a very complex business, more complex than any other, and probably as complex as many other types of industry are all added together. Aviation, operational production, engineering, nuclear power, sustainable innovation, etc., etc. We have to embrace the learning from all of these systems, including the very deep understanding of the people who we serve, those people whose ill health or concern about their ill health brings them into our clinic, into our hospital, and into our surgeries. We need to adapt our thinking. So many of the tools we do use to improve quality in healthcare are in themselves very useful, but they need to be modified and adapted to be maximally useful in the work in which we do. And thirdly, that co-producing a service design and indeed an output and an outcome is invariably something that's best done with the patient rather than for the patient. We've moved on, I think, in the last decade, indefinitely, from a very paternalistic approach to the provision of healthcare to something much more akin to a shared ownership of the issues and a shared responsibility for delivering them, whether that's around how we plan a service or whether it's about how we organize the care we give so that it gives the person the best opportunity to participate well and get the best outcome from what modern day healthcare can provide. And that really gives me my last point, which is that the measure of our success is actually about the outcome for the patient and their family. Yes, it's about the money. Yes, it's about the buildings. Yes, it's about professional satisfaction. But first and foremost, it should be about the outcome for the person in front of us, what they wish for the rest of their life, and how we can make sure that that has the best chance of being achieved with the minimum disruption. So I thought I would start with a very commonly used analogy about tools and toolboxes. The idea being that if you think all you've got is a hammer, then everything else has to be a nail, because that's what a hammer does well. In fact, it's really all that a hammer does. Putting a screw in with a hammer is not very successful. Putting a nut on a bolt with a hammer is impossible. And as we know, two pictures from India here, that the people that we serve and the people that we care for are very, very different in what's the matter with them, what potentially its impact could be, and what they wish to happen in their present and in their future around their health and their expectation of their life and its goals and achievements. So we really have to think about how we move to the heart of the issue, which is that quality is complex. And so our tools and our toolbox needs to be well organized, flexible, as well as having a lot of things in it. The Institute of Medicine's definition of quality is where I always ask our teams to start, because I think sometimes quality means different things to different people. And unless we're all on the same page, thinking about the same sorts of things, we can easily overlook the most important aspects of quality in the minds of our colleagues, but also mostly in the minds of our patients. Quality is about safe care. It is about care that is timely in accordance with it being maximally effective. It's care that is efficient use of our time, our resources, and of course, the patient's time and the patient's resources too. It also must be equitable. Whether I'm rich, whether I'm poor, whether I live in a rural community or in the middle of a city, we should be aiming to make sure that the care that we offer is as effective, as timely, as safe, and lastly, as person-centered as it possibly can be, as well as being equally person-centered, irrespective of those circumstances. This isn't easy, and nobody said it was easy, and if it was easy, we'd probably all not be spending a great deal of time talking about it and thinking about it. So our toolbox has to be well organized. It has to have a lot of familiar objects in it, and perhaps some that are less familiar. We have to use our minds and think very consciously and very conscientiously about what we use, when we use it, and what the impact of that choice might be. And lastly, we have to use our head, our heart, our hands, and our legs. This is an action-based activity. Quality isn't something to be talked about alone. It is something that we must do something about as well. We may have to involve the whole system. Yes, of course, staff, clinical staff within and with outside the hospital setting are obviously the key proponents of quality healthcare. We are the experts in our own field, but we are also the ones that connect and can connect easily and consistently with each other. But I would also advocate that unless we use communities and schools, social workers, the police, the local authorities, charities, sports groups, religious groups, community champions, then we are failing in our opportunity to really create a cohesive approach to quality of care for patients. And of course, as well, unless we involve the families, the patients themselves, their friends and relatives, we miss out on a huge opportunity to really make quality that matters most to them at the forefront of our design, and to make sure that we're not doing things in a way that actually diminishes the overarching quality of what we set out to achieve. So the whole system may not need to be involved, but it should be involved. And if you're not involving it, you should ask your questions of yourselves. Is there a reason why we haven't done that? And is there every reason why we should? So the second point I want to make in general terms is this idea of the complexity in which we work. The idea that, yes, this is all about technologies and equipment, the patient, what's the matter with them, the team, who's in it, the task, whether it's simple, complex, whether multiple things have to be sequenced for the best outcome for everybody, as well as, of course, the work environment, whether it's chaotic, whether it's organized, whether it's modern, whether it's traditional, whether the technology that we have is old or brand new. And of course, this impacts on our work as professionals and how we work together with each other. It impacts on how we work with patients in a collaborative way. And it, of course, impacts on how the patient and their family can receive our care, can interact with our system and our intentions, and can respond to it. And all these things interact together to create outcomes for the patients themselves, for us as professionals in our sense of achievement, the effectiveness with which we undertake our professional work, and that sense of satisfaction that is so wonderful to have at the end of a day and at the end of a week and at the end of a year. And then, of course, those outcomes for society and community, and indeed the organizations for whom we work, where there's optimal value, optimal reputational enhancement, and optimal use of all the resources that a society puts into healthcare that are desperately needed, but must be definitely used to best effect every moment of the day. So I go back to Don Abedian's concept that actually outcomes come from processes and our systems of work. And if you want to bring this very much up to speed, I have a quote here, a very recent paper on this idea that it's systems that engineer patient outcomes and professional care in a way that is extremely complex, and that any simple toolbox that we might take to hand needs to be understood in the context of this overarching complexity. And if we fail to do that, we will fail to understand that where those overlaps happen is also the place where there's the most risk that things can go wrong. To build on that, I would really recommend that you start to try and conceptualize how we use tools by thinking about what's going on in your system at the moment. What is it that we're seeing when we look at quality in the care that we deliver? Because what really happens is not always what we intended to happen, or indeed what actually is happening when we do either a spot audit or a more comprehensive audit. And I think this has been clearly expanded on, articulated and written about by two safety experts, Charles Vincent and René Amalberti. And this concept most recently has evolved into what I think and colleagues find extremely useful, this framework where we can think about not just what's gone wrong, but also where do we start? Because often the biggest challenge for clinicians, not least doctors, is we want to fix a very difficult and challenging and often big problem. And where to start can seem overwhelming and difficult to conceptualize or just to decide on what we're going to do first, because everything seems to be necessary and everything seems to be disordered. And that can be paralyzing. And as I've said, if we don't get moving and get acting, nothing will improve at all. So I have found this particular idea of optimal care, quality, versus very suboptimal care, a useful grid to refer to when you're looking at what's going on at the moment. Was care as envisaged by the standard delivered? And if it was, did that happen every time for every patient? And if there are some imperfections, if there was some unreliability in there that led to poor care, but the patient escaped significant or serious harm, then that is an opportunity to optimize the current way the work is done, to dig down into how things are done and to try and get rid of those gaps and those problems and those unreliable moments. If, when you look at what happened, it was poor care with either minor or even possibly overarching lack of benefit, harm, and perhaps even worst of all, serious morbidity and mortality, then we need to intervene to look at how we are looking at risk, how we are managing the dynamics of care, and how we need to rethink possibly the whole system in which the care is delivered. Now, I say that because the important difference is then the tools that we might start with. If we need to optimize what we're doing, then we can quite legitimately start with a human factors analysis, with process mapping, with looking at reliability, and perhaps the more technical way of looking at the system and checking where the failures most often happen, failure mode, and then dealing with that actively, promptly, and now. If there has been serious harm, or worst of all, mortality, then we need to take the lid off the box and look in a much more systems-wide way. What were we trying to achieve? What was going on? Where were the risks? Did we spot them? Did we have mitigating events in there that we could have dealt with differently? Can we simulate these events going forward in order to rehearse a better way of dealing with this? And do we need to completely rethink what we're doing, how we're doing it, and how we're working together, possibly across the system? So all those three components, the work system, the professional system, as well as with patients and our colleagues. Because to get care reliably delivered every day for everyone needs constant attention and often very specific improvement approaches. So with that in mind, I draw us back to where we often start. We often start with a standard, whether that's one that's recently been put together through new evidence, perhaps something that's spun out of the pandemic, or whether it's a standard that's been around for a while and has just been flagged up that in our institution is not being met. So we select a sample, we look at the reality of the work we do day in, day out with what we really should be aiming to achieve. We identify the gaps, and then, as the audit cycle says, we make improvements and we go back and re-audit. Now, what I want to do is expand on this make improvements, or indeed the imply improvement methodology, because it's this place that is complex, that we need our toolbox, we need our minds, we need our energy, and we need our hearts. And it isn't just about using the standard improvement methodologies that we'll be familiar with and that you may be familiar with. It's about using them wisely and a whole load of other things too. And that's what I want to talk about for the remains mostly of my talk today. Yes, improvement methodology is about a methodology. It is about a conceptual framework. It is about being clear about what we want to achieve and by how much and by when. But it is also about all of this. It's about understanding the system, understanding the variation, making sure that the stakeholders we need are involved, at least they know what's happening, ideally that they're actively working with us. We do need to come up with ideas from all parts of the system. Nobody has the only right to have an idea. We need to have all the people on the team that could possibly contribute. And we need to work across several components of our system, if not simultaneously, at least in sequence, because it's almost certainly the case that one part of our system will lead to the necessity of changes being made in another. If we don't know that the ideas we're putting into practice are making an improvement, we are likely to make things either get worse or, worst of all, make no changes at all and have unintended consequences where we weren't looking. Enthusiasm is key, and we need to embed the changes we make so there's no chance of things going back to how they were. And we need to share an evidence so that those are perhaps who are most skeptical, even at this stage of our improvement journey, can become partners in what we carry on doing and what we do in the future. So there's a lot more to improvement methodology than this, which is a grid a colleague of mine put together for some work we did here in the NHS in England. And people were getting very agitated about what method should I use. So we put them all on a grid, all the main ones: Model for Improvement, Six Sigma, Lean, Theory of Constraints, Experience-Based Co-Design, and we put the guidelines and we put the key approaches. But actually, the key to all of these is that they're all rooted in frontline plan, do, study, act cycles. That idea that we need to test it out as we do it in a safe and controlled way, because we really don't know it's working until it's tested out in the reality of the complexity of our daily work. And just having a tool on its own is not going to be enough, because these tools in themselves won't answer all those questions and won't ensure that the system is fully understood, the right people are involved, that there's energy in the team, and that we know for certain that the changes we're making are not just changes, but they are improvements that are substantial and are sustainable and that have changed the outcomes for the persons we serve. So let's just look at this list in a little bit more detail. And I just want to highlight pictorially now how we might think about this sequence of 10 steps. So I've taken the first three. How might we understand the system, the variation in it, and get stakeholder involvement? Well, the first thing to get is people together in an informal way, if you can, and look at actually what's going on. Experiences from different people, from different places with different responsibilities. We almost certainly will want to have what's called a fishbone analysis. This is often a key way that teams can start to understand what goes on in their system that isn't just their specific role within it. And I really recommend this as one of the early steps you take in your team to start to think creatively and imaginatively about the work you do and who does it, with whom, and how. We need to understand the variation in our system. And I really encourage this idea of doing small audits about the sequence of processes in a sequence of care. Here I've taken the use of early warning score, this idea that we monitor people to see how well they are, how stable they are, and then we do something about what that system is telling us in a prompt and orderly way. And sometimes, like this particular system here, they audited what should have been extremely well-delivered care and discovered it was extremely unreliable care. That they sometimes couldn't even count the numbers that they were calculating, just 3, to get the right indicator of the severity of the patient and how they were improving or deteriorating. And as a result, any escalation, even if it had been timely and appropriate, was less likely to succeed. Because we know in reliability science that the more steps there are, the more important it is that every single step is at least 90% reliable, or the overall sequence of events becomes incredibly unreliable, as you see here in this first column. Even 4 steps being 90% reliable, our overall system of care is only 2/3 reliable. Not what we would be wanting to achieve, and definitely not what we should be aiming to achieve if you want the best outcome for patients. And then, of course, this idea that we conceptualize what we want to do about our complex system in a way that people can easily grasp and then easily see where their ideas feed into the actions that we're going to undertake next, feed into, perhaps in this case, what happens with the hospital service or the patient or home, and how this feeds over time into that brave, bold aim that we've set ourselves, which is to improve a big part of our system that's got lots of issues in it that need to be resolved. So these are the ways you understand the system, you check for variation and realize it's more than you anticipated, and create that involvement of people in the work you're going to do next. And then you can come together in a bigger group and start to decide about, well, what should we do? Do we get the right, have we got everybody we need here? How do we work together? And how can we do lots of different things, ideally at the same time, if we can, if we're a bigger team, because we know that several different things need to be changed to make this a sustainable shift in performance. Yes, the model of improvement is a great place to start, because there needs to be clarity about what is it we're trying to achieve here in terms that matter to us as professionals, but most importantly, matter to the patients themselves. Then we need to decide, just like we would with a sick person, well, how would we know that their fever was improving? How would we know that their cardiac function was improving? How would we know that their kidneys were working better? How would we know that the changes we were making to our system at work were an improvement? Because if we can be clear about that before we start doing things, then we can measure the impact of what we do very clearly from the very beginning. And then our ideas should be small enough to be undertaken in a small test tomorrow by agreed people in an agreed way, in an agreed situation, with the intention to see how it goes, to analyze it, and to reflect on what happens. And then to adapt it, to adopt it, or sometimes to abandon it and take up another idea that we've come up with that we think now on reflection might be better. Yes, we can document our work in lean or 5S thinking, a very powerful way to look at some aspects of our work where systems and processes are well used, especially if there's technology involved. Yes, we can just hand draw a process map together and see what we're missing and what we didn't know about. I'm the doctor, I don't know necessarily what happens in the admin side of my radiology department, and I didn't always know what was going on in the radiographic side of my department if the team had decided to undertake work in a way that was different from we'd last spoken about it. But a process map is a jolly good way of everybody getting clarity about what actually does happen at every part of the sequence. And I do also recommend that you really reflect on the microsystems approach, which clearly asks people to involve patients, either immediately and directly, or at least by asking their views, their ideas, listening to their comments, their compliments, their complaints, their observations. Because if we don't do that, we're likely to miss a great deal of our understanding that's necessary to really design what happens optimally for them. And after all, that is the purpose behind the work that we do. So how would we know that our ideas are making improvements? All improvement needs change, but not all change is necessarily an improvement. And we need to understand how we measure across the system to be sure that we're not having unintended consequences and that the improvements we're looking for are starting to happen in our system. They often don't happen immediately. In fact, sometimes when you measure clearly and specifically, things look like they're getting slightly worse. That's because you're paying more attention and being more critical of what's going on. And that's absolutely vital. But regular, frequent measurement not only gives you the evidence you need to show that the improvements are starting to happen, but it also keeps people motivated, enthusiastic about the effort that they're having to put in, that it's starting to actually make those differences that we all come to work every morning to make. The difference to the patient, to their sense of health, of well-being, and their sense of hope that whatever it is that they come to us with is starting to be resolved and starting to be improved upon and starting, hopefully, to be cured or be on the way to being managed and dealt with. So I recommend that if the Plan, Do, Study, Act cycle that you're intending doesn't fit on one sheet of A4 paper, it's not a proper PDSA. It's a big plan, it's a big implementation, there's too much in it. A Plan, Do, Study, Act cycle is something two of us can do tomorrow with a couple of patients in our clinic to try out, to review, and to assess. It has to be something that fits with our aim. It has to be clear in theory terms why we think this idea is likely to make an improvement. And we should be in a position to predict what we want to see. We want the consultation to give the patient more information, to get better feedback from our clinical colleagues, that the report I gave them as a radiologist really fitted what they needed in the clinic at that time. That we're going to do this with less equipment or more swiftly, or the patient's admission or the time we take to prepare them for admission or discharge will be shorter and better. Prediction is a way of really holding us to account, that our theory is well grounded and that our intention is both ethical, moral, practical, and professional. And if the plan is small and doable, people won't feel it's too big to manage in their busy working day. So we're going to do one that's developed an idea, then we're going to do another one to test it, and then we're going to implement the change as we get better at working in that way and refining exactly how we do it. And we're going to keep records so we know and can legitimately justify the modifications that we've made. And we're going to keep data. We're going to measure weekly, fortnightly, monthly, and we're going to look at samples so that we know that the changes that we're making are actually starting to shift the performance of our system. We're not going to wait for months before we look, because if we do, people's enthusiasm, motivation, and indeed our learning will be taking a back seat and won't be at the forefront of our mind. And that will lead to us intrinsically being more motivated because we're being explicit about the progress that we're making. Then how do we embed the improvement so it can't revert back to the old way of working? And alongside that, how do we create the evidence that will persuade others and perhaps share more widely the approach so that others further away from us can take hope and take inspiration from what we've done and make it work in their system, possibly with a few adaptations. Well, we can create a structure and an environment that makes improvement the forefront of what we do. A whiteboard where we keep notes for our meetings, a coffee machine if that's appropriate, so people can come and both refresh their energy levels as well as refresh their understanding of how the improvement's working. That we put our results up there so people can feel proud and positive about the extra effort that they've put in. We can create documents and structures and perhaps guides and helps for us in our clinical work so that we are steered to delivering more reliable care, more often to more people. Doesn't stop us personalizing it whenever it's necessary, but if we can standardize a lot of what we do and need to do for everyone in the same way, we can become much more effective and efficient as professionals, even if we're incredibly busy. We need to create this story so that the early and late majority, who can often be the ones most resistant to doing work in a new way, or perhaps skeptical of the progress that's been made. The evidence that we create through patient feedback, through our own feedback, and through the data we collect is a very powerful way to make sure that everyone understands the value of what's going on and can join in with confidence, with positivity, and with that sense of enhanced professionalism, that we really are doing a great job every day for everybody. And again, to reflect, to discuss, and to work together as a team and as a wider team, and possibly also to involve organizations like CAHO, or in this case, a colleague of mine who is a surgeon, being able to talk really widely to all the surgeons in training across the UK of his improvement journey around surgical related infections. And then lastly, I absolutely promote publication, whether it's a poster at a local conference or whether it's something national or international. We can all learn and share from each other's work in small and large and significant ways. And if we start off understanding the ISQua guidelines as an approach, then we can adapt the evidence that we've created for any of those arenas and be really well able to share and spread our knowledge and enthusiasm. So a few questions here just to raise our game, because this isn't just about quality tools. It isn't just about context and having a wider stakeholder involvement. It's about involving patients and their families at every step of the way. We should be collaborating, not just consulting. We should ask them how it can be made better, not just a closed question if this is or isn't any good. And we must listen to their ideas about what needs adding and also what needs taking away, what is actually making the hard work we do less than optimal for them. We should be asking ourselves, which people are we designing this service for? Where do they live? What resources do they have? What do they need to live healthy and healthier lives? And are we helping them in that way? Or are we creating barriers that they need to navigate? How can we help them become better in their wellness, more able to participate as patients if they have a long-term condition, and better able to get the benefits that modern healthcare and its delivery can undoubtedly provide? And if you haven't got these questions built into what you're doing, then you need to go back and ask yourself, what matters to our patients and to the reputation of our service? Have we put our patients in the driving seat of our improvement, or are they still backseat passengers? And I suppose I personally have learnt this most in the last few years when I've been working very seriously and very intimately in pediatrics with children and young people with diabetes, a disease they didn't choose to get. There's nothing to do with their lifestyle choices that gives a child or a young person type 1 diabetes. And it's a disease they have for life. And when you ask them what matters to them, it's interesting the answers that you get. What matters to them most is to feel that they can do just what any other child without diabetes can do. And that the way we organize their clinics, their support, their medication, their ability to self-manage should be about that. It shouldn't be about necessarily just their HbA1c, which is what we can focus as technical, scientifically driven clinicians. It's about how we give them the courage to have, if they are able, continuous monitoring devices and use them for their health and well-being. It isn't about the numbers that they give us on a monthly or a quarterly basis. And if that technology isn't available for our young people, is how do we work with them to help them understand that their disease is complex, but these are the tools they personally can use to make sure that their time in the right glucose range is optimized for them every moment of the day, whatever they want to do with that day. So on that note, I just wanted to finish my talk to you with perhaps the most important part of the toolbox that we should use for quality. That is us personally, us as professionals, as clinicians, as scientists, as technicians, but also us, hopefully, as curious, empathetic, optimism that we can always make things better, thinking critically about our own work and the way we do it, not just the work and the system of others, that our ability to synthesize complex things together, make connections in the evidence we see, but also in the way we work with other people. And that we're resilient and comfortable if there are differences of thought or differences of view, or perhaps differences of aim and objective. And that we come together because the most important thing we do is ensure that the people we serve get better. They get better from an acute event, and they get a better future as a result of managing a long-term condition with us together, fruitfully and successfully. So perhaps a starting point after today is to just read The Habits of Improver again and remind yourself that these are important personal attributes that we could all enhance in ourselves and perhaps help each other by doing so. So here is a list of further reading. Many of these things I have covered very briefly today, but I didn't want to restate what's available in other arenas. But here is a go-to list for you. And remember that providing the highest quality of care is a duty. It's a privilege and it's a challenge. And perhaps the best thing about it is that it's a team sport that can ride the rapids with confidence if you've got the right team culture, the best teamwork, and a comprehensive and adaptable toolkit. Nothing is too difficult. And I thank you for the opportunity to discuss this with you today in your CAHO webinar series.
To start with the questions, first and foremost is that last 20 months have put a lot of things behind in the hospitals, especially large hospitals like us, who treated a large number of COVID patients. A lot of things which we routinely practiced in terms of patient safety and the various procedures and checklists and all, a lot of things really didn't work at all because our focus was totally on COVID care. However, we are now coming back to the mainstream activities, and the numbers are luckily reduced in our country. First thing is that what I could gather from the presentation is that there is a lot needs to be done, and we are not really doing that much that you have presented. It's really a good way forward for us, firstly. And secondly, to take a specific example of, say, for example, the antibiotic stewardship management in the hospitals is a very, very important topic, even very well emphasized by the WHO also. We try to do that. However, the kind of participation or involvement of the clinicians is not really, forthcoming. We try, and we try to bring make an antibiotic policy. We see what antibiotics need to be this thing. So what is that what kind of a tool can be adopted in such a system? Though clinicians realize that they understand that what antibiotics are all, we are already using 3rd generation, 4th generation, it's all exhausting. There is no more antibiotics left. But still, the use is as before. There is no much of a change. We have introduced how if you jump to a 3rd generation without this thing, you have to give justification. So in spite of that, it's experience tells us this, experience tells us that. So this is what happens in at least large hospital like ours. So what is the way forward? What is the kind of quality tool that can be used with little, with fragile egos and things like that? How do we go about? So this is my first question.
Well, that's let me take it in 2 parts. First of all, your experience in India is absolutely replicated everywhere. We are in exactly the same situation here in the UK, in that everything else got paralyzed, and now it's not a disrespectful statement, but people are a little bit like, we would call it rabbits in the headlights. Like there's this huge thing, and so everybody's kind of dazzled and doesn't know what to do. And I suppose my point would be is we do know what to do. So, but we have to take it in bite-sized pieces, because if we are dazzled by the enormity of it, then nothing will happen. And much of what I've described today would be a reasonable approach. And in fact, in some situations, it's not like we're having to reinvent how we best provide some surgical care effectively and efficiently. We will have done it like that before. We just need to remember what the key ingredients of it were and put it back into the system, allocating a space in our minds and in our organizations to do it. And I think a lot of the older ways of doing things, we'd already changed. So the idea that we would have telephone triage preoperatively, bring people in on the day of surgery with or without a COVID test now, that we would run them through a system as perhaps day cases, with day units being open till the evening for patients that can go home safely. And we seem to have lost some of this memory in all the chaos that has happened in the last 18 months. And so I suppose my plea would be for clinical teams to say, okay, what matters most in our service? What is adrift most? Cancer patients, hip replacements, people being admitted for 24-hour tapes in cardiology. Let's just pick one thing and look at it and fix it with the knowledge we already had, with some adaptation because of the circumstances we're in now. And then your second point about antibiotic stewardship. Interestingly enough, it's been picked up here in my region, which is small compared with India. There's 5.5 million people, 16 hospitals, and already a network of people working together. And what we've decided to do is set up a virtual collaborative. The idea being that the answers to this are known. They're about what is the diagnosis? Is an antibiotic appropriate? Which one is it? How long should it be given for and in what way? What else do we do around our system to reduce resistance, to reduce hospital-acquired infection, to improve the outcome for patients by checking their renal failure or lack of it, and so on and so on. We're not necessarily creating new science. We just need to make it happen every day for everybody in every institution. And so we've taken a lesson out of the COVID book and said, okay, we're not going to get everybody together. Nobody's got the time or the energy. And in fact, we're not allowed to get together at the moment. but we can do it like this. So tomorrow, we're running a 6-hour workshop. We've got 32 teams from across our region. We've got a patient story, we've got best practice, we've got a lead clinician to kind of gather the troops. We're running some improvement sessions on taking people back to basics about PDSA cycles, about root cause analysis, about fishbone analysis and so on. And then we're giving them time together as a team to plan what they're going to do tomorrow, not what they're going to do in the future. And so what they're going to do tomorrow has to be small enough to be doable. And we're going to take it small steps over 9 months. So I suppose in answer to your question is the knowledge and the approach is already there. We've just got to remind ourselves and make the task achievable. Because if we focus on one thing, there will be spin-offs in other aspects of our work, because there always are positive spin-offs. And I think if we can see the results of what we're doing and feel the sense of satisfaction, then also that will build teams' resilience, which undoubtedly has taken a big knock in the last 18 months. All clinical staff and institutions are worn down really by the stress and the energy that they've had to put in to the pandemic. And both these things I've just described to you are great ways of building energy back in. So I hope that answers in some way your huge question and perhaps gives people permission to start small, because that's how we get stuff done.
Thank you, ma'am. Thank you. First question is this, what the person is saying is that I have a question on implementation of any of the tools madam is discussed. That's number one. Can we modify any of the parameters as per our convenience in the tools, even if it deteriorate the core principle of the tool? Example, medication error review chart, NCC MERP.
Well, I suppose in principle, my view has always been, I'm not obsessional about a brand of improvement methodology. I am not obsessional about carrying out the methodology exactly as it might be prescribed in the textbook. But I am obsessional about understanding the principle and keeping to the moral, ethical, and intended purpose of the tool. So I always say it's much easier to start with somebody else's medication reconciliation document than to start with a blank sheet of paper. It's very easy to, we would call it, pick holes in it and want to change it. But when you want to change what somebody else has worked on in another institution or another department, just remind yourselves of what you're trying to achieve with it and whether they did achieve that with their tool. And if they did, are there any specific reasons in your institution or your specialty or your circumstances that mean you have to adapt it? And if you think there are, try out the original first. And your theory then is this won't quite work. You know, our patients speak another language, or our patients are in a rural community, or our patients, we do video conferencing and video consultations. They're not in front of us. Fine. But I'd always rather people test it out, their wish to change something first, rather than just change it because this thing was made somewhere else.
Yes, ma'am. So there is one more question. They're asking, what is the best tool for learning from error or defects or mistakes?
Well, two here. Okay, so you're on a ward round and it's just become apparent that there was an error or a mistake yesterday for the patient in front of you. The best tool to deal with that is to stop the line, as the lean thinkers would say, as the lead consultant or the attending or the registrar, and I have junior doctors in front of me and nurses, say, okay, let's just do a rapid action review. What happened? What should have happened? And what have we learned? No blame, no accusation. We don't want names. We just want to understand the situation. Now, that is a very powerful way to immediately understand whether there's a systemic problem or whether this was just, one of those specific circumstances, although of course it can always happen again. And it tells you immediately together, actually, that we are all in this together. And maybe we need to do something now that makes the chances of that happening again infinitely smaller. The second tool is to, with an open mind, take a sample of your work, 20 or 30 patients maybe, and check against what's happened to them and what should have happened to them. And take that as your guide as to whether or not the right thing happens to everybody in the right way every time. And I'm telling you, that is unlikely to be the case. And then that is your guide. Because I think if we collect and want to collect huge amounts of data, then the harm that's happening in our system is still going on while we're looking at the problem. And the only way to make it less likely is to do something, which means we need to know what needs to be done first. And as scientists, that means we have to look in a little bit more granularity about what's happening. And then choose the tools I've mentioned and others and go through that sequence of 10 steps.
Yes, ma'am. So the next question is, how can teams overcome fear in the context of change? Good question. Would I repeat this, madam?
Yeah, how can an aim deal with fear?
How can teams overcome fear in the context of change?
Okay, that is a great question. I think in a variety of ways. And perhaps this is where understanding the qualities of your own team and colleagues and how to coach each other is maybe the magic ingredient. Because fear comes from different places for different people. Fear of failure, fear of the unknown, fear of being found out because you're not up to date, fear of not being able to do it differently, a fear of the fact that actually this is going to be hard work and I might have to stay late every night, or I might not get my Friday afternoons off. All these are different for different people at different times and sometimes in different combinations. So I would say that improvement methods are a leveler. So we go back to what should be happening. Why does it matter? And we build up a confidence that we can identify the best areas to go first, that we're going to do it in small steps. And if it is disruptive to somebody's work-life balance, or if there are unintended consequences that somebody's seen once before and think will become prevalent if we do it like that, then we'll see it and we'll deal with it. And that we're all in this together. This isn't about making the work harder, more stressful, more difficult. It's about doing the opposite of all of that and getting a better outcome for the patient. So I think reflecting, and if you wanted something to read about it, if you go into some of the micro systems into their website, Clinical Microsystems, and read about team building, that's what we use in our collaborative at the very beginning. We get teams to think differently about their meetings, to rotate the roles in the meeting so that they're all sharing responsibility for leading, agenda, documentation, timing, and so on. That there's always a facilitator looking for the person that looks a bit uncomfortable about what's happening and what's going on, is a bit disengaged, and working to bring them into the conversation, to find out what's worrying them. Because I think if we can externalize and be explicit, then fear is conquerable.
So we go to the next question, ma'am. This is how would one assess the tool required where we are measuring outcome at more than one level? For example, the discharge effectiveness with outcome measure.
Great question. So I think this probably goes back to the concept of having a measurement strategy from the beginning, and understanding that the outcome that you're aiming for, whether that's a successful discharge and the patient doesn't come back in with a complication or a problem, or whether it's 5-year survival rate from a cancer surgery, or HbA1c, under 55 in our units here. The outcomes way down the line. And there's a temptation to be too focused on that and not to understand the system that's delivering the outcome. And so that when you're measuring, you should be measuring, well, what are we doing? Our processes, are they being undertaken as we intended? Could we improve on them? What are the outputs? So, is there more engagement with the patient? Is the patient attending all their clinic appointments? Are they adhering to their chemotherapy? Did they turn up for their follow-up mammogram or whatever it is? And then the outcome is down the track. But one thing's for certain, the outcome is not going to shift where it could if all those preceding things aren't happening as they need to. So, it's a bit like early warning. I suppose an analogy would be, I know we're all talking about climate change at the moment, but so we know, don't we, that we had rain this week in our country. It was coming down at about 1 inch an hour. Well, I can tell you for a fact that the drainage system around where I live can't cope with 1 inch an hour rate of rain. And as soon as that's happened for 2 hours in a row, we have flooding. So I could measure how the drainage system is working, whether it can absorb 1 inch an hour or maybe 2 inches an hour because I've improved it. And then when I get that event where I have 2 hours of rain at that rate, I'll be pretty confident that it will soak away. I don't really want to wait for another day like yesterday to find out whether my system worked or not. So, we have to kind of look at the whole thing and look at it in a little bit more of a sort of systematic way, and understand what it is that generates the benefit we really want to see, and check that those things are happening as we intend.
Thank you very much, Dr. Tricia.
So as a mark of our appreciation, I would request Dr. Ravindran Jagasoti to present a certificate to honor Dr. Tricia. Over to you, Dr. Ravindran.
Thank you, Lalu. Tricia, I think you have been a very excellent talk that you have provided us. You have achieved all your learning objectives. So it's my pleasure on behalf of CAHO to present this virtual certificate to you. Thank you, Dr. Tricia.
Thank you for the invitation. Thank you. Thank you very much.
Thank you very much, dear participants from across the globe, for joining us.